The biggest problem is that most adults aren't actually doing enough exercise. And so rather than worrying about the athlete's heart, for those who are doing a good job, I guess we really need to remember that guidelines recommend both cardiovascular and strength training. And really, you've got to find something you love and make sure you're doing enough of it, I think.
Hi, Jessica. It's my pleasure to have you on Evidence Strong Show. If you could briefly introduce yourself.
Thanks so much, Alex. It's a pleasure to be here. So my name's Jessica Orchard. I'm an associate professor in the School of Public Health at the University of Sydney, and my research focus is on cardiac screening, particularly cardiac screening of athletes and people who are doing high-level elite exercise with a view to prevention of major sudden cardiac events and just promotion of athlete health in a cardiac sense as well.
Okay, and part of your job is directing ARENA. So could you just speak a little bit about that too?
Yeah, of course. So ARENA is a registry of athlete screening ECGs, so the Australasian Registry of ECGs in national athletes, because we had to have an acronym. And that's really collecting and centralising all the records of elite athletes who undergo cardiac screening in Australia and hopefully New Zealand as well. We'd like to include their data. And that's really saying a lot of sports are doing cardiac screening of athletes, but let's have a look at the data and see what we're finding. What are the rates of diagnosis of major cardiac conditions? What are the clinical outcomes in terms of long-term events? And importantly, are there any differences in certain types of sporting disciplines in athletes or between male and female athletes that we need to take better account of? So really looking at some of those more underrepresented groups as well.
Could you give us a general idea what athlete's heart is?
Yeah, absolutely. So we know that exercise is really good for you in so many ways, and it has a powerful effect on cardiac structure and function, really. So in the long term, sort of regular exercise promotes what we would call structural, functional, and electrical remodeling of the heart. And that's exactly what we often call athlete's heart. So how much that happens depends on exercise dose and intensity and a whole range of other factors like sex, genetics, environmental things perhaps. But in general terms, we talk about those types of changes. And we know that electrical changes are often visible on an electrocardiogram or ECG. So they're things like sinus bradycardia, a slow resting heart rate under 60 beats per minute, an increase in voltage criteria perhaps, so chamber enlargement, and also things like repolarization anomalies. So there's actual changes in the function of the ion channels and really these changes, much more the electrical ones, visible on ECG. When we talk about functional changes, that's things like an enhanced filling and an increase in stroke volume. And structural changes are changes in cavity size and wall thickness, particularly on the left side. And that really does depend a little bit on the type of exercise you do, what sorts of changes you see there. But essentially, as you start to exercise, your heart will contract faster and your circulation will increase. And that's get oxygenated blood to your muscles quicker. So as the demand increases, your heart rate increases and it contracts with more force. So your heart rate and stroke volume increase, creating increased cardiac output. So all these changes of athlete's heart are really to help your heart perform in the way you need it to for the exercise that you're doing.
Okay, so this is in general. Now, if we speak about power athletes or strength athletes, many of my viewers or listeners will be related to Olympic weightlifting. Are there specific adaptations that this group of athletes will likely experience?
Yeah, definitely. That's a really good question. And so we now know, based on lots of evidence, that there are quite different changes that you see in a strength training athlete, sometimes called static sports and very commonly weightlifting, versus sort of the other end of the spectrum, which is endurance athletes. And then, of course, there's all sorts of combinations in between. But when you're looking at strength trained athletes, that commonly leads to what they call concentric hypertrophy of the left ventricle. So that's thickening of the walls, but not so much a change in left ventricular chamber size. So the changes in strength athletes are caused by pressure overload, I guess, accompanying the sort of high systemic arterial pressure found in this type of exercise. So that sort of blood pressure goes up, and that's the sort of training you do in that type of a sport. And so strength trained athletes are really showing this concentric left ventricular hypertrophy and an increased ratio of wall thickness to radius. So if you look at the other side of the coin, the endurance athletes, they tend to get mild to moderate but sort of eccentric left ventricular hypertrophy, but then they get right ventricular ventricular dilation and biatrial enlargement as well. So it definitely is a bit different, particularly in the sort of structural changes that you might see if you were to image a whole lot of athletes, though you would see those different sorts of changes. And then, of course, all the things in between and the sports that involve really a combination of the two, you might see really quite profound remodeling in some athletes, yeah.
So now, if we know that some level of adaptation is expected, how do athletes and coaches and parents should be thinking about, oh, is this normal, or did we cross the line and this is better?
It's a really good question, and I guess a lot of it depends on the context. So most of the time, if everything's going fine and you've got no symptoms, no family history and nothing to worry about, you won't actually know how much your heart's adapted because you might not, unless you've been going to cardiac screening or something like that. So you'll just maybe feel like you're getting fitter at your run or like what you're trying to do is a little bit easier as part of your training. If you're getting cardiac screening, it might be evident on the ECG because you might see some of those athlete heart changes. And we've got a lot better at distinguishing between what's normal and what's not in an ECG because we've just got so much more data now that's available to us. And so that's now much easier. There are always a few, not as many as there used to be, always a few where you're not quite sure. And that's where a lot of clinical context might come in. So if that person says, you know what, I have suddenly been feeling, I've got a sudden loss of a cylinder or something when I'm training, it doesn't feel like, if there's anything like that, that's when you might be more suspicious that there's something wrong. Whereas if somebody just said, no, I'm completely normal, the only reason I'm here is my ECG looks like this, I don't have any family history, I don't have anything else, then you'd be less worried in your testing. But sometimes for a very small number of people, it's a bit harder to make that decision. And I guess if you are in one of those situations, it's really important to be as informed as you can be about family history. I keep talking about that because a lot of the conditions you might be worried about or looking for are cardiomyopathies or things like that can be inherited. And so if you've got a family member that's died suddenly under the age of 40, even if you don't know what it's from, perhaps a drowning on their own, but it was unexpected, or even a single vehicle car accident can be caused by something like that if there was no other potential cause. So knowing something about your family history can be useful. And of course, if you are seeing a doctor about something to do with your heart, being very honest about whether you think you've had any symptoms or if you're perhaps taking any medication or supplement that could be an issue.
While we on the supplements, are there any supplements athletes should be avoiding or can influence heart?
There definitely are some, and there are other medications, just pharmaceuticals and things that can affect your heart. I think one of the things that we probably should mention if we're talking about strength training athletes is that we do know that the slight elephant in the room is that some people perhaps do take supplements and maybe anabolic steroid or similar sort of agents, and they absolutely can have very serious side effects on the heart. And I'm not sure if people always realise that there could be a bit of a risk there. So there are cases of people who've taken anabolic steroids and ended up with steroid-induced cardiomyopathy where they've had a normal heart before because they've had some kind of imaging, and the steroids have actually caused changes in the heart muscle structure because they change your other muscles, so why not the heart, I guess. It's thought to be through androgen receptors expressed on cardiac myocytes, sort of really right down into the cellular changes, and those changes show that you can permanently weaken the heart by having taken steroids like that. So, and you can have major heart failure and other problems that come with that. So I think for anyone who either has taken or is considering taking something like that, it's very important to understand that those can bring significant risks that were not there before. So we do know that. There are other things, party drugs like cocaine, things like that, certainly not great for your heart, but I guess that's in a slightly different category because you're probably not taking that for a performance reason. But if you're taking something purely for performance, it's very important to understand that.
I have a follow-up question on steroids. So you said in the long term, they weaken the heart. So the reason to take them is to get stronger or possibly bigger muscles. So why at the end, after prolonged use, we end up with weaker heart instead of stronger heart?
Yeah, I guess that's a really interesting question, and I probably don't know the exact details of that. It's actually something that's quite hard to study because you need people to tell you that they've been taking steroids for a long time, and you need to get an ethics approval to sort of really investigate what's a little bit of an edgy topic. There certainly are a few studies that show the cardiomyopathy, because that's something you can document if somebody comes in with something. The idea that they weaken the heart is, I guess, that they can sort of lead to heart failure, and the heart being too thick means it can't pump in the way that it needs to, is sort of the summary of that. So the risks of heart failure are certainly things that can go. I think if that sort of thing, we're talking sort of prolonged use and potentially higher doses. And the other thing, I suppose, with steroids is perhaps it's not always clear exactly what you're getting, if you're getting it from someone, or you might be trying a different one, and it may not be perfectly known what the impact of being on that particular one is versus that one and at that dose for that period, because this is a lot of this would be a bit hidden, and so that lack of knowledge is part of the picture as well.
Thank you for that. How long does it take for the heart to adapt? If I prepare for marathon for 3 months, am I getting some adaptations towards the endurance athlete heart, or do I have to do it for? What is the time frame?
Yeah, that's a really good question. So, yes is the short answer to the example you gave. So, usually we talk about an athlete as someone who's exercising about 4 or 5 hours a week of decent exercise. And that's not just strolling down to the bus sort of thing, but decent level exercise. And so, some studies suggest that about even 3 hours a week for 3 months, you might start to see some of those changes. Yeah, 3 hours of maybe quite decent level intensity, but 3 hours of running's not nothing, for example, or other things that you might be doing, like intense cycling or things like that. And so one of the easiest ways that people can tell is, a lot of people might have a smartwatch or something now, and you can see your resting heart rate go down. So you might, before you start exercising, be somewhere in the 60s or 70s, and then you might drop down to be what we would call bradycardic, so below 60 beats a minute, and that's just your heart getting fitter and more efficient. It sort of doesn't have to do as much as it did before. So that's one of the very easy ways you can tell.
We talked a little bit about time frame. Are there any other factors that may influence heart adaptations?
Yeah, I guess as we mentioned, we know that sex, genetics, and exercise dose and intensity are really the major factors. We know that female athletes definitely get athletes' heart changes as well. They're also related to the sport. A lot of the time in cardiology, we don't have enough data on females, despite they make up a big proportion. And so as we've gone on, we've had more and more data, particularly of really top level female athletes, and they certainly get those changes as well. Some of them might be slightly different, or in the context of perhaps a slightly smaller heart compared to males. So we do know that's something as well. There is some thought that there might be some conditions that are a little bit exercise-induced. So exercise-induced arrhythmogenic cardiomyopathy has been described. And that's, I guess, some people wonder whether there's an underlying genetic predisposition that, when you combine it with the environment and some very high level training, can almost sort of switch that on in some people. And that's a really interesting concept, I think. So previously you would think of arrhythmogenic cardiomyopathy as being much more of a genetic thing, but perhaps it's sort of, there's a bit of a curve, and beyond a certain point in some people under some conditions, perhaps that's something that can occur. So I think there are some things we don't know at the same time. And most of the time, to be honest, the slight issues that you can get as a result of too much exercise or a lot of overtraining, perhaps, they are things you tend to see more in the endurance athletes, and that's something that I guess is just a function of the time and the amount you're pushing your heart. So things like atrial fibrillation, or perhaps other supraventricular tachycardias, are something that are definitely, we know the risk is a bit higher in endurance athletes. But something like an atrial fibrillation, for most people, it's a bit annoying, but it's not a terrible thing that's going to cause you to have a cardiac arrest, And so people who absolutely love going out and doing a 200-kilometre ride every weekend up the highest mountain they can find, perhaps that's just another risk along with falling off your bike, if that makes sense. So it's really interesting. We do know a few of the things that influence how your heart changes according to exercise, and really there's probably a few more that we don't know, and we're still looking at data for.
Do you have a lot of, in the arena registry, do you have a lot of strength and power athletes?
The majority at the moment in there are mixed sport athletes, which is a catch-all term for a lot. We definitely have a few, and the ones we do have the very top level, so they're from the Australian Institute of Sport, Victorian Institute of Sport, and so range of ages, and hopefully what we'll be able to get is interesting data over time. So where an athlete gets screened multiple times across their career, we'll be able to sort of follow some of those changes. Obviously, it might be a little bit different in recreational or other competitions. We did mention anabolic steroids, so presuming anyone in the Olympics is sort of subject to very careful drug testing and perhaps would not be taking that risk anywhere. So we may not be able to answer some of those questions without specific data on sort of groups that are doing that. But we will be able to, as we gather more data, really look at more of the changes in strength athletes, because I think you just often need quite a big data set and quite a length of time to properly look in some of those ways.
Awesome. So fingers crossed it's coming in the next few years.
Yes.
Okay, the main question, I guess, is the athlete's heart adaptation good or bad? And should we be preventing it?
Well, I think you'd have to say it's generally good. So most of these changes benign most of the time. They increase the heart's ability to pump blood effectively, enhancing stroke volume to meet performance demands. The heart's a muscle and you're wanting it to grow stronger and more efficient. So most of the time, it's a really good thing. Just like a lot of things, occasionally in a small subset of athletes, as we said, high levels of endurance exercise in particular can lead to sort of electrical remodeling, which can lead to rhythm problems like atrial fibrillation, and we know that there are some associations. If anyone's interested in that, there's a great book called The Haywire Heart by John Mandrola and a couple of other excellent endurance athletes where they look at that in detail. But I really think it's important to say the biggest problem is that most adults aren't actually doing enough exercise. And so rather than worrying about the athlete's heart, for those who are doing a good job, I guess we really need to remember that guidelines recommend both cardiovascular and strength training. And really, you've got to find something you love and make sure you're doing enough of it, I think. And so that would be the best thing you can do for your heart, is to make sure you are following the guidelines at least and doing some good exercise.
So the follow-up question on this is, weightlifters and powerlifters don't particularly enjoy running. Is lifting heavy weights repeatedly considered cardio, or should the athletes do more? Should they add running or some other modality that is more lower intensity but longer in time?
I guess it depends what you're training for is the answer. And so my personal trainer sometimes comments on what certain athletes are doing, like a cricketer who's just run a half a marathon in a quite fast time. He would say, yeah, but does he need that for what he's trying to do? I guess so. That's one question. And the other question is just for general health. So I think you would probably call all sorts of weightlifting. That's really under the heading of strength resistance training. And if you're looking at the guidelines, you probably do need a reasonable amount of moderate to vigorous physical activity. It doesn't have to be running. Could be swimming, could be cycling, could be brisk walking, and many other things. It probably for your health is good to add that as well. Whether it helps you perform better as a weightlifter is probably a separate question, if that makes sense.
All right, fair enough. What would be your take-home message or the main advice for coaches and athletes of strength and power sports in terms of the heart?
Well, I think it's great that you're doing exercise, and if you found something you love, make sure you're doing plenty of it and enjoy it. Equally, if you've got a symptom that's worrying you about your heart, get it checked. So just because you're very fit, very strong, doesn't mean you can't have a problem. So if you've got an arrhythmia or you've got sort of fainting associated with exercise, a worrying family history, or any change that is worrying you, it's really important to get that checked. Remember that some supplements and anabolic agents can have really important and serious cardiac risks. And certainly if you have been taking them and then you're seeing someone about your heart, it's important to disclose that so that they can treat you properly. And the other one, I guess, is that while exercise is enormously beneficial for your health, just because you're an athlete doesn't give you a free pass with other modifiable risk factors, especially as we get older. And so you still got to think about your diet. Perhaps if you're a smoker, your overall weight, blood pressure, cholesterol. These things are all still really important to watch. And then the one last one is a final word about emergency response. We shouldn't ever really talk about heart health without mentioning it. So everyone should aim to be trained in CPR and the use of a defibrillator. If you're at a gym or a sporting venue, many of these venues do have defibrillators, and that's a really, really good thing. So if somebody around you was to collapse suddenly, it would be really nice if you know where it is and if you could be part of helping run to get it. And so I guess the final word on this is to say that any collapse should be treated as cardiac until it's proven otherwise. And that's a really important message.
Awesome. Thank you so much. 2 short questions to finish. The first one is, what is your favorite exercise?
I love to run, and I also love to see my personal trainer for all the strength-based stuff that I can't do at home. So I do know that sometimes he brings out the bigger weights for other people, but I really felt like that strength training's helped my running, but also just good to be a bit stronger. So I love doing that outside in the park. So that's been really nice. Yeah.
Okay, and the last question is where people can find you if they want to follow your work or keep up with your research.
Yeah, definitely. I've got a profile page at the University of Sydney. So if you just search my name and the University of Sydney. The ARENA project also has a profile page. So if you search ARENA University of Sydney, one of those results will be the ARENA gym and the other one will be the ARENA project, which is our work. And that's a nice similarity. I'm also on Google Scholar and X and Blue Sky.
Awesome. Thank you so much, Jessica. It was a pleasure.
Thank you so much, Alex. Pleasure.